Why talk about sex? Interesting question. Let me tell you why we should all be doing so. So you can see here, Bernie Zilbergel's fantastic book that I've referenced at the end talks about good sex usually takes place within the context of a good relationship. And it's no new thing. It's been around for centuries. And we can see here these nude art forms, which are beautiful and actually just help us to think about how we see nudity and how we see sex, either individually ourselves or in the workplace. This statement from the World Health Organization absolutely blew me away in 1999 when I was at a clinical meeting about erectile dysfunction. And it mentions here about the fundamental rights for an individual and the right to sexual health and a capacity to enjoy and control sexual and reproductive behavior. But it also mentions here about freedom from fear, shame, and guilt, and false beliefs and other factors which inhibit our sexual response, and that can impair sexual relationships. And the big thing here is freedom from organic disorders, disease and deficiencies that interfere with sexual and reproductive function. And prostate disease certainly does. I've been around a while. So in 94, I came into this field. And then in 96, here I am in this groovy, horrendous trouser suit. I started talking about it. And I developed an information package called the Erection Connection to get people to just have simple language to understand a bit about erectile dysfunction, because I was trialing Viagra at the time. And I picked up how difficult it was for me to talk about it, let alone the patients. And some of you here listening and watching this will be thinking, I really feel comfortable about talking about it. Well, that's fantastic. But I expect there are many of you thinking, I feel awkward. It feels really difficult to broach the subject, because that's how I started feeling in 94. And the more I've done it, it's now water off a duck's back. Then in 2009, Prostate Cancer UK, or Prostate UK as it was then, we started to talk about sex and prostate cancer. But it wasn't until 2014 that there have been any guidelines available to help us direct patients and their partners about best practice and care. What really excited me in 2022 was when we had international guidelines developed by November. And jointly, there is some work going on with PCUK UK in November to really spread the news about these. And you can see I've highlighted in orange, there should be this pre-treatment education and assessment and a baseline outcome, evaluation of patient and partner's sexual function, the distress and how they're coping as a couple. I would say that being given the diagnosis of prostate cancer often impacts an individual or a couple's dynamic regarding their sexual well-being. And sometimes they may find it really difficult to talk about it with the clinician because it may all be around the cancer care and surviving. But I've had many a man say to me they would rather have not had treatment but have died potent and not be in the situation where they feel emasculated. So let's remember this about discussing things right at the very beginning of the patient's diagnosis. And age is no barrier. So David Bailey, a famous photographer who's photographed amazing women around the world, only recently at age 83 was saying that he still likes having sex. And it made me think, in fact, yesterday, I love browsing in chemists, seeing what's there. And I happened to be in Boots yesterday. And there was an older couple looking at the lubricants, and it just brought a smile to my face seeing them. So I felt like tapping them on the shoulder, actually, and saying, do you need any help? So our psychological well-being is as important as our physical well-being. And it gives that holistic approach. And sexuality is expressed in many ways, not just intercourse. Outercourse can be fun, and it's good for our self-esteem. So let me show you a visual reminder here. The brain is attached to the genitalia. And this is the emoji sign for a penis. And then we have a vulva. And so if we connect these up with the brain, we're really giving holistic care. But there's also Ian Smith. I think the power of social media. Ian contacted me. He had prostate cancer himself, and then he decided to study photography. And he's done some amazing artwork around prostate cancer. And this prostate gap was a real gap in his artwork, where he realized he wasn't reaching out to the people he'd originally photographed, which were heterosexual couples in his first piece of work. And we jointly put these roller things together to help people display them. So I've got one in the south, he has one in the north. His has done a few more trips than mine. He's had it in libraries, he's had it in hospitals. So again, this could be something that could be used to raise awareness. And if anybody needs to borrow mine, they're welcome to do so. But remember, when I was doing the Viagra trials back in the 90s, I can remember thinking, wow, this is incredible. This tablet's really having an impact, where previous to the tablet, we only had injections and vacuums. But we have to remember that this thinking the erection problem will be simply treated with medication is this magical thinking, and it removes the emotion and the intimate relationship from a sexual response. And sadly, I think that's what's often thought about when we're looking at what's frequently mentioned about penile rehab. It is not just about the penis. We've got to look at that whole person and the relationship. So what steps can you take to promote sexual well-being in your practice? And just take 30 seconds to have a think about what you're doing now. Is there something you could do better? Something that you are doing and it's worked really well, because then you can help share that with others, like hopefully I'm doing with you today. It's teamwork. We've got multidisciplinary team meetings. And remember the 4 C's: cancer, continence, cock, and clitoris. And here I am as part of a team at the Prostate Centre, and we've all got our different roles here. I would really like to see in the future that there is a sex therapist part of the MDT. Professional accountability is really important. I have a confidentiality agreement that I go through with all patients that I see, and I can break that confidentiality agreement if there is something that raises my awareness. For example, there may be someone having underage sex, and I can break my confidentiality. I expect a lot of you are saying, oh, we haven't got sex therapists in our area. I wouldn't even know where to begin. Simple thing is, look up on the College of Sexual and Relationship Therapists website. You can put in the area where you work, and it will give you a list of therapists in the area. You may have some in your sexual health clinic. Pick up the phone, have a coffee with them, and connect. Because I think even if you don't have a regular sex therapist on the MDT, even if you did once a month, once every 2 months, or a resource that you can ring up and say, look, I've got this far, I don't know what else to do, any tips? And hopefully we'll really start to bring about the change where no longer will the sexual well-being be an unmet need for patients and their partners. And we've seen things change a lot over the years with the MDT, where we've got oncologists, CNSs, surgeons, radiologists, and we're all having to prove our accountability. Setting the scene. So you can see behind me in my room here, I've got some things around that will hopefully help people feel comfortable when I'm doing remote consultations, that it's okay to talk to me about sex. And in my clinical room, I've gone to the dizzy heights of a nice trolley with lots of drawers and bits that's lockable. But some of the vibrators in there are quite expensive and I don't want them stolen. But I did start off with a drawer of a desk, and I have a toolbox. Here it is on the bottom right, and I have it here at the side of me. And I'm quite well known for my toolbox, traveling around with it and what's in there. So just think about your clinical setting. I've got books over here. And I've got the erection hardness score, which is the blue on the desk. So it helps me to evaluate things as I'm talking to the patient. Always encourage a partner to come along. It's amazing what you can get if you just ask the couple, tell me what's going on for you with your sexual life at the moment. Leave that silence. If you leave that silence, they'll talk. If you butt in, they won't, and neither will an individual. But they'll just pour out, and you will be able to contain that time. Because again, timing can be something, oh, I haven't got time, I've got a busy clinic, I've only got 10 minutes with a patient. You may have to do it in multiple appointments, but at least if you allow that discussion to take place and you raise that awareness in the first appointment, that will actually start things happening. So books, you know, the new male sexuality, have that on the desk, have it behind you, have it in the drawer. Anything that helps you to get the trigger of a visuals thing. I have the rainbow there as well. It's on the desk and I have it here behind me. So it helps people to feel more comfortable talking about the gender if that's an individual thing that I've not addressed prior to the appointment. So sexual orientation, we should all be asking about it. And there was the Equality Act that came out in 2010. So I do. Sexual orientation, I ask about all my patients, because how can I give individualized care unless I know about their needs? And I still remember to this day about a gentleman back in the 90s who had not told the surgeon who was doing his radical prostatectomy that he was a gay man. But on the first appointment with me, he immediately told me. And I thought that was quite interesting that he chose me to tell as a clinical nurse specialist in erectile dysfunction at the time, rather than the surgeon. So there was something there that made him feel relaxed. And if I was to help him, I had to know about the whole him. Are we just paying lip service? You can see here on this picture, looks like a pair of lips, a couple of lipsticks. But actually, the middle with the cap off isn't a lipstick, it's a vibrator. So the patient sat in front of you, you have no idea what's going on for them as an individual. How are they feeling about their sexual selves? I hear the holistic needs assessment is filled in. You might get the International Index of Erectile Function complete or the SHIN. But what do you do with that information? Do you just file it, tick a box that you've done it? Are you actually actioning anything that they're telling you about regarding any sexual difficulties? To assess erectile function, that is absolutely part of it. I know the medical history, you know, when patients had a radical prostatectomy, patients having radiotherapy, they've certainly been the group of patients in the past that have been badly managed regarding sexual well-being. Sexual history. Somebody may be having sex with someone other than their wife or their husband even. So you don't know. Is it sudden onset? Is it gradual onset? Often with surgery, we've got this sudden onset of loss of erections. With radiotherapy, we may have a gradual decline. I do use the erection hardness score because it's a good tool, if you excuse the pun, of communicating. I can write to a healthcare professional and say the gentleman achieves grade 4 prior to surgery, where the penis is completely hard and fully rigid, a bit like our forehead, it's really hard. But a squidgy, soft marshmallow like our nose is 1. Penis is larger but not hard. We've even got tumescence, penile tumescence, that bit of thickening. It doesn't even register as penis is larger but not hard, but patients might say, there's a bit of something going on down there. And definitely ask, what have you tried from the internet? There's such shame and taboo around sex that frequently men will spend fortunes, and it may be partners too, buying all sorts of things that have got not any credibility to them, or constituents are very poor that the drug is made up of. I remember being at a meeting when the fraud team were there from the company. At the time, when Viagra was being made, and some of the blue colouring was road paint, and there was amphetamine mixed in with small amounts of sildenafil, and it was being made abroad. It was shocking to see. So asking patients what they've tried, again, will be really helpful because it will get them talking to you about what they have tried that hasn't worked. It might be there wasn't an active drug in it. So the SHIM, that's 5 questions from the International Index of Erectile Function that I've previously mentioned. And you can see it here. So you could give this to your patients at the time of their appointment to complete. I do prefer the IIEF, and the IIEF has been used and validated in all the clinical trials regarding erectile dysfunction treatments. It tells us about erectile function, intercourse satisfaction, orgasmic function, sexual desire, and overall satisfaction. So that takes us back to thinking not just about the penis. Sean Ralph did this pivotal work back in 21 now, but there was nothing out there regarding anal sex and the pathway for patients regarding the management of their prostate cancer. So now we've got this. It's a really good resource that we can refer to and share with patients if that arises during a consultation. And hopefully it will if they feel comfortable to talk to you about doing so. So what's in the management toolbox? Well, we talk about sexual rehabilitation and being fit for surgery. And I think that's all part of it. Are you fit for sex? Being able to walk a mile on the flat without getting short of breath, you're generally fit for sex. I do believe psychosexual therapy should be part of that. And sometimes the lifestyle change is the initial thing. So certainly regarding sexual activity, if someone's really tired and they're having radiotherapy, they may like to be intimate in an afternoon. When they've had their radiotherapy, they may change their level of intimacy, and it may not be about being the more active partner in sex play, but being more the receptive. And that sort of thing can be discussed. Combining treatment, vacuum devices, oral pharmacotherapy, creams and pellets and injections and implants. So there's actually quite a lot there that can be considered. But I have to say, not many patients get to know about all of these treatments. And it's not up for us to say what a patient should be having when and where. I was recently speaking at a meeting at the European Society of Sexual Medicine, and the patient spoke about his experience of prostate cancer, and he eventually had a penile implant inserted, and the huge relief that gave him. And listening to his experience of depression, difficulty with his relationship, it was palpable in the room. And he wished he'd heard earlier about penile implants. And he didn't have any discussion initially about any treatments or any support about his psychosocial self. And he felt he was having to just get it from the internet and from whatever source he could. Now, that was only about 2 weeks ago in 24, and that should not be the case. So hopefully after this, you'll all be go off spreading the word about how to help. Now, in the NHS, men are able to get a medical exemption certificate, certainly if they've had prostate cancer and if they've got an illness on this list. It allows them to get treatments free of charge. And that should not be limited, but it often is, to 4 treatments a month on the NHS, because the original guideline in September 98, when Viagra was launched, that's when this guideline came about, and it's called Schedule 2. But now, certainly with some of the tablets like Viagra, Cialis, they're much cheaper generic, and it isn't so restrictive on cost implications. So the medical exemption certificate is provided by their GP for anybody with a cancer diagnosis, male or female, and it gives them 5 years of free prescriptions if they're under prescription age. So the tablets, we've got sildenafil, tadalafil, vardenafil, and avanafil. I do tell patients about them. I usually start regarding sildenafil and tadalafil. They need sexual stimulation. They will not work without it. And they shouldn't use them with nitrates because they drop your blood pressure slightly, and so do nitrates. And they give that natural erection. But what we must remember here is certainly the men post-radical prostatectomy, often they will not respond to this medication because of the impact around the nerve supply. And I always use this when I'm talking to patients to show them where the prostate gland was or is if it's prior to surgery, and about the nerve response and getting the erection and what's required, a good nerve supply and a blood supply and touch and stimulation. And that often needs your head to be in the right place. There is a lot of talk about penile rehab, giving men 5 milligram daily tadalafil, and it should be taken for the minimum of 5 days to get to the basic level in the bloodstream, which runs at about a 13 milligram level. And theoretically, it can help with nocturnal erections and reinstate erectile function as nerve recovery hopefully will take place. That recovery can take 3 to 4 years, and I have had men who have experienced some recovery 5 years down the line. But there's a lot of debate on how active penile rehabilitation is and the evidence behind it. But it certainly can help some men get some tumescence, get some early morning response on occasions. And if it isn't good enough for the sex play that they would like, whether that's vaginal, oral, anal sex, that's something to bear in mind. Side effect profiles also differ. So if I get a gentleman with horrendous side effects with tadalafil, for example, a small number of men can get flu-like symptoms, leg aching, lower back pain, then I would switch them on to a shorter acting sildenafil drug. Sildenafil is in the bloodstream for about 4 to 6 hours. Tadalafil is for about 24 to 36 hours. And I've subsequently gone on to the other PD5 inhibitors if men have found they've not been responsive or the side effect profiles being poor. Most men, when you mention 200 milligrams of avanafil, their eyes pop out because they think this is super strength drug, but it isn't. It's just the way the compound's being put together. Topical alprostadil Viteros is in an applicator. I don't have huge responses with it, but some men say, you know, I'd like to try it. Keep it in the fridge. When you take it out, roll it between your hands so it loosens a little bit. The consistency of it's a small amount. Take the cap off. And then if the patient opens up the glands of the penis and puts this over the top and presses the plunger down, some of the gel drips into the urethra. And then some of it will just sit on the top and that can be rubbed in. And that may help a man get an erection. I have had some men say it stings as a side effect and they'll get, they'll wipe it off. It might take a few times for it to be effective. But I do say to people, it doesn't have a high success rate in my clinical experience because men often come very downhearted and disappointed when erectile dysfunction happens. And if it just doesn't work for them, then they think, what's wrong with me? And they feel more useless than they might be feeling already. So it helps to manage their expectations. Intraurethral alprostadil is a pellet that you insert down the end of the urethra. I have to say at the moment in the UK, we have a problem with obtaining this. In fact, it's not available as of today, which is in March 24, but hopefully we'll hear something this year. In the plastic applicator, there is a waxy pellet. It's very small, about the size of a grain of rice. 250, 500 and 1,000 micrograms are the different doses. I usually start with 500 micrograms and increase to 1,000 if 500 micrograms doesn't work. It can cause penile pain as a side effect. So starting at 500 micrograms, you've got an easier knowing about the discomfort. Use once only. The patient urinates, so the end of their penis is wet, and then they will slip the cap off. And because it's wet and slippery, slips down, and then you push the pellet down and it dispenses pellet. You can see it, the little yellow area in the urethra. Wiggle this back and forth so the pellet stays in the urethra. Throw that away and massage the penis, rolling it back and forth. Partners can insert it in foreplay. It causes tingling of the lips and it can taste bitter with oral sex. I've had that anecdotally told back to me rather than being written anywhere. But that is Muse for when we have it in stock. Injections. I adore them. I'm not sadistic. I like an outcome. And so do men. And men, sir, is the last thing I ever want to do is put a needle in my cock, dick, penis, whatever the word they like to use. And that's a really important thing to ask them because, again, it helps about language. It's tiny, the needle. It's a little bit bigger than an insulin needle. You might be able to see that against the white wall background. And unfortunately, there is a manufacturing issue at the moment with Cavijet dual chamber. 2 chambers to it, similar needle, well, it's the same needle that goes on the end. But Viridal Duo we do have available in the UK. And with Viridal Duo, it's in an applicator that you use. You get a little pouch here. You get the plastic applicator here and the glass vial. And in the glass vial, you have a powder and a liquid. And the powder and the liquid mix together when you push the plunger together. So I think you can see there, we've got powder at the bottom, powder at the top, liquid at the bottom, and the needle at the top. Use once only. So I insert the glass vial into the plastic applicator, and there's a groove at the top, and that slides in, and that slides on, and screws together tight. And then we screw the needle on, and it has 2 covers to it. And then when you push the plunger up, you mix them together and you dispel the air. Whenever you use an injection, although the BNF says start with 2.5 micrograms, I start with 5 micrograms and only gradually increase the dose in 5 microgram increments. That's really important so the patient doesn't develop a priapism, which is a medical emergency. So imagine your penis as a clock. 12 o'clock is the dorsal vein, which we can see on this diagram. 6 o'clock is the urethra, which is the white area with the hole in that the patient pees through. But when you inject avoiding veins, which are a little bit like what's on the back of your hand, and you go in at a 2 o'clock position or a 10 o'clock position. You alternate the injection site. Use once in 24 hours, a maximum of 3 times a week. But as I say, it can raise the dead. It doesn't need the nerve supply to be working. So it's really effective. And remember, some of our patients with prostate cancer may have had pre-existing erectile dysfunction. In fact, it often is the case. So that's why it's really important that we get that assessment done right at the beginning. Invicorp is another injection that's not alprostadil. Some men can get pain with alprostadil. If that is the case and it doesn't settle down, I'll switch to Invicorp, which doesn't cause the pain. Vacuum devices, there are several on the market. This is one. All men should be using these. 6 weeks post-surgery or get one pre-surgery to practice with. All the radiotherapy, the hormone patients should all be using a vacuum. You've got to be able to keep penile length and girth. And when you've been knocked out with your desire and nothing's going to allow that erection to happen, you need to be getting the penis moving. And it's like physio. And I'm sucking on my hand here, and in a minute you'll hear it. It's like a champagne bottle popping. And it has rings, and the rings hold the erection, but you don't keep the rings on for more than half an hour. But that gets the man thinking about their sexual self. Penile implants. The surgeon who sizes the patient for these, obviously, it's a really important thing to do. The corpus cavernosa is scooped out and they're sized. This is an inflatable prosthesis. You can also get a malleable prosthesis, and the malleable one will bend. So this is a reservoir of water, which you can see here on this picture. It's collapsed at the front of where the bladder is. Yellow is the bladder. And the pump sits in between the balls, the testicles in the scrotum. So the pump pumps the liquid from the reservoir to fill the chambers to allow the erection to occur. But the erection can go soft again by holding the pump in the opposite direction, and the liquid will go back into the reservoir and the penis is soft. The malleable means the patient always has the erection. They'll just be bent away. There are the pictures on the bottom, away and down in the trousers to put the erection away. And psychosexual therapy, I think you've probably got a bit of a feel of what I've been talking about, that it's managing expectations. Sometimes we've got to dispel the myths and misconceptions. I want all people to be masturbating, to know how it's feeling, what the outcomes are like. It might be that they want to masturbate with a partner watching, which they've never done before because they felt awkward and embarrassed, but it actually keeps that intimacy and connection going. Talking about the normal sexual response, that we actually need to be able to get desire started off in our brain to allow our organs to fill with blood. So talking about very simple things is a really easy thing for you to do, but you may not have had that confidence in yourself to do that with patients. Self-focus is masturbatory techniques. Sensate focus is, I will sometimes say to patients, I don't want you to be thinking about having intercourse, but let's just think about how you can rekindle intimacy and the outer course. And it might be about caressing the whole body. The skin is a massive erogenous zone, but without touching the breasts or touching genitalia. Getting people to communicate with each other. The tasks are all done at home and in the privacy of their home. So thinking outside the box, and this is where you could be hopefully feeling invigorated, saying, oh, you know, what else could I bring to my clinic that could help? I talk about vaginal dilators. I've got some here. I've got the smallest size and the largest. It's quite interesting that the number of men I see, it may be that their female partner may have their own health issues. I've had gynecological cancers. They may have had breast cancer and they're having treatments. They may not have had penetrative sex for a long time with the menopause. And so talking about vaginal trainers can be really helpful. The circles that you can see on the picture are O-nuts and they cushion. So you don't have to have deep penetration. You can put however many rings you want to prevent the depth. Lubricants, there are a variety of lubricants around. I'm a great fan of Uberlube. It's a silicone lube. They do small canisters that you can travel with, which are very nice. There's anal lube, there's organic lube. I tend to shy away from lubes with xanthan gum in. It can cause thrush and irritability. The least ingredients in a lube, the better. And do not use anything from the kitchen. Make sure they're for genitalia use. Age is no barrier, as I keep on saying. Don't judge people by their relationship status. And that picture about touch never gets old. And sex toys, that supermarket basket was actually me in a supermarket where I bought what I needed for breakfast and then spotted the vibrators. And patients can buy them, they can bring sex toys into their repertoire, and they don't have to feel they can have to go to a sex shop. They might be able to get them in the supermarket. And it just brings up this conversation, because sex is adult fun, isn't it? And the use of senses, touch, smell, taste, and hearing. You know, we have that when we have a meal. You're sat watching this. You might be sat watching with a cup of tea or a glass of wine and just taking in things. And each time it might be a bit different how you hear things. And that's the same for sex. We might want quick sex. We might like longer sex. And so getting people to think about, you know, the sounds and the smells that make them feel relaxed. So in summary, we've got to make sure patients and partners feel valued and the problem is important. You can use those three words. In my experience, patients with prostate disease, it impacts on their sex lives and sexual well-being. Let me know. I can help you with that. And if you don't know the answer to a question, you can say, I'll find out for you and I'll tell you at your next appointment. Discuss expectations of treatment, provide safe websites, maybe do a crib sheet where you can direct people to information. I mean, what's great is PCUK and Macmillan, November. There are some great documents that you can get for your clinic and you can give out or you can direct people to and hyperlink patients to. I do that quite a lot when I see patients. Address that discussion between the patient and the partner. Just listening, giving them that time to talk to each other. How are you feeling since your surgery? How are you feeling now, to the partner? Because partners often feel they're not being helped in any shape or form. Book a follow-up appointment. Involve other teams. It's multidisciplinary, and that includes primary care. People want to be involved because they want to give a positive outcome. Don't let patients feel they're stuck in this tunnel. I looked at that and just thought, oh God, there's so many things as I'm walking to that tunnel it's making me think of. So an appropriate choice of medication that meets the patient's needs, a vacuum pump, access to an ED clinic, psychosexual clinics, really important. We've got about 650 sex therapists as part of COSRT, and there are other organisations too. Relate have sex therapists. They're untapped resources that we need to improve on. Questionnaires, posters and leaflets, books, websites, leaflets here. That's a reading list I hope you will find helpful. And that's me. And if I can ever help anybody to be encouraged to get on there and feel more confident, just get in touch with me, because that's what's important. We're all singing from the same sheet and improving patient care. Thank you.